If your GI just prescribed a biologic for your fistula and nobody has mentioned draining it first, stop, because there's something really important you need to understand before that first dose. Hi, I'm Kate, and today we're talking about perianal fistulas, abscesses, and the specific reason the order of treatment genuinely matters. Not just a little, but potentially the difference between your biologic working and it not working at all. This is one of those conversations that doesn't happen often enough in a rushed clinic appointment, and I want to make sure you have it before you move forward. In my practice, I work with a lot of people navigating perianal Crohn's, and I'll be honest, it's one of the most distressing presentations there is. It's painful, it's embarrassing to talk about, it affects every part of daily life, sitting, walking, working, sleeping, and by the time someone gets a biologic prescribed, they are often so relieved that something is finally being done that they don't ask many questions. They just want it to start working. I completely understand that. My husband lived with Crohn's complications for years before finding stability, and I know what it's like to be in that place where you will do anything to get some relief. That desperation is real, and it's valid. My husband still talks about having a fistula at 17, and it's like you can see the trauma written all over his face. But here's what I see happen. Sometimes people start a biologic, they wait, and the fistula doesn't close. The biologic isn't failing because it's the wrong drug. Sometimes it's failing because the environment it's trying to work in hasn't been prepared properly. And here's what I want to talk you through today. So here's what most people, and honestly even some clinicians in busy settings, they don't explain clearly enough. There's an important distinction between a fistula and an abscess, and they are not the same problem even though they often exist together. A fistula, it's an abnormal tunnel, a channel that forms through your tissue, usually connecting the bowel to the skin surface near your anus. That tunnel is the Crohn's disease process at work. That's what the biologic is targeting. An abscess is a pocket of active infection, pus, bacteria, pressure, heat. It's your body trying to wall off something that it can't clear on its own. Now here's the critical piece. If there is an undrained abscess sitting alongside or around that fistula, which is pretty common, and you start a biologic, you are introducing a powerful immune modulating medication into a body that is actively fighting a bacterial infection. Biologics work by dialing down parts of your immune response. That's the whole mechanism. But if your immune system is already in the middle of battling a septic process, an abscess, dialing it down doesn't help at all. It can actually allow that infection to spread further, faster, and deeper. We're talking about a risk of serious systemic infection. The way I explain it to patients is this. Imagine you're trying to paint over a wet wall. You can have the best quality paint in the world, you can apply it perfectly, but if the surface underneath is still wet and unstable, the paint will not adhere to it. It will peel, bubble, and fail, not because the paint is bad, but because the conditions weren't correct. So, drain the abscess first, stabilize the environment, then the biologic has something solid to work with. That's the reframe. It's not about doubting your medication, it's about sequencing your care correctly. So let's get practical. Here is a clear action framework. Specific questions to ask your GI and your surgeon before you start or restart a biologic for perianal fistula disease. Okay. First of all, you need to confirm whether an abscess is present right now. You need imaging before you start a biologic for perianal disease. Full stop. The gold standard is an MRI of the pelvis, specifically an MRI fistula protocol. This gives your surgical and gastro team a map. It shows them where the fistula tract runs, how many tracts there are, and critically, whether there is an abscess present that hasn't fully drained or that isn't visible on the surface. An examination under anesthesia called an EUA is also sometimes used, particularly by colorectal surgeons, because they can both assess and treat at the same time. The question to ask your GI is, before I start this biologic, has imaging confirmed there's no undrained abscess? If they say yes, great. Ask to see that it was documented. If they look uncertain or if it's been a while since imaging was done, advocate for an updated imaging before your first dose. Okay, step 2. Understand the surgical step, the seton. If an abscess is found, it needs to be drained. That's typically done surgically under anesthesia by a colorectal surgeon. And in many cases, after draining, the surgeon will place something called a seton stitch, a small, loose thread or silicone drain that sits through the fistula tract and keeps it open. I know that sounds counterintuitive. Why would you want to keep it open? Because a fistula that closes over the top while infection or inflammation is still present underneath will just abscess again. The seton allows ongoing drainage while the biologic does its deeper work, calming the Crohn's inflammation from the inside. The seton and the biologic work as a team. The seton manages the acute local environment. The biologic addresses the underlying immune-driven disease. Neither one alone is as effective as both together, sequenced correctly. So ask your surgeon, will a seton be placed? How long will it stay in before we release or reassess closure? These are completely reasonable questions, and a good colorectal surgeon who works with IBD patients will actually expect them. So step 3, make sure your gastroenterologist and your surgeon are actually talking to each other. It sounds obvious, but as you know, it's not always happening. Perianal Crohn's management sits right at the intersection of gastroenterology and colorectal surgery, and the best outcomes happen when these two clinicians are coordinating, ideally in a multidisciplinary team setting. What you want to avoid is your GI prescribing a biologic on one timeline and your surgeon planning a procedure on a completely separate one, with no one checking whether those timelines align. The questions to ask both of them is, are you and my other specialist in communication about the sequencing of my treatment? If the answer is vague, you can be the one who connects the dots. Bring a written summary of what each has told you to your next appointment with the other. You are allowed to be the coordinator of your own care. Step 4. Know the infection warning signs once you do start your biologic. Once the abscess has been properly drained, the seton is in place, and your team has given the green light to start your biologic, that is the right time. But your job doesn't stop there. Biologics, well, they're serious medications. They do modulate immune function, so you need to know what to watch for. Signs that something is going wrong include fever, especially anything over 38 degrees, increasing pain or swelling in the perianal area, new discharge that looks or smells different, or feeling genuinely unwell and flu-like after a dose. Any of these symptoms warrant same-day contact with your medical team. Not a wait and see, not a message through the patient portal that might take 3 days to get answered, a phone call, because infection plus a biologic can escalate quickly and early intervention changes outcomes significantly. Step 5. Support the whole environment, not just the fistula. This is where my naturopathic lens comes in, and I want to be clear. Everything I've just described is the medical framework, and it is non-negotiable. But alongside that framework, the body's capacity to respond to treatment is also influenced by nutritional status, gut microbiome, health, stress load, and sleep. These things are not alternative to medical care. They are the foundation that medical care builds on. Malnutrition is genuinely common in people with perianal Crohn's because pain and fear of eating can lead to a significant restriction. If your body is depleted going into a biologic, it has less to work with. Getting proper nutritional support, whether through a dietitian experienced in IBD, through elemental nutrition if your GI recommends it, or through targeted supplements under guidance, is part of preparing that environment well. This is something I work on with my clients in my practice, and it's something worth raising with your team. What nutritional support should I have in place before and during biologic therapy? Now, we started with a very specific scenario. A biologic has been prescribed and no one has mentioned draining the fistula first. If that's you, I hope what you're leaving with today is not fear, but clarity and confidence. Clarity about why the sequencing matters, and confidence to walk into your next appointment and ask the questions that will help your treatment actually work the way it's supposed to. The biologic is not the enemy. The abscess is not a sign you're beyond help. The sequence is the thing. Get the environment right, get your team coordinating, and give that medication the best possible conditions to do its job. People do achieve deep remission from perianal Crohn's. It takes the right medical team, the right order of treatment, and a patient who understands enough to advocate for themselves. So that's what today was all about. If this helped you understand something that wasn't explained clearly before, please share it. Someone in a Crohn's community you're part of might be sitting with a biologic prescription and the same unanswered questions right now. If you want support in navigating the naturopathic side of your Crohn's journey alongside your medical care, come and find me. My details are below, and the Crohn's Method community is there for you. I'll see you in the next video. Have a beautiful day.